looking at robotic surgery for ventral hernia repairs with permanent mesh, comparing patients who are non-Hispanic Black versus white. We have no disclosures. So the robotic approach is rapidly being adopted from a study that looked at cases just over 5 years from 2012 to 2017 in one state found that the robotic approach went from just 0.5% of all ventral hernia repairs to 22.4%. And with the adoption of any new technology, there's always an opportunity for us to provide this equitably, but there's also a chance that surgical disparities widen whenever something new comes along. And so we were interested in looking at whether or not robotic approaches were being equitably offered to Black versus white patients, and also looking at their outcomes with the addition of this robotic approach after ventral hernia to see if patient outcomes remain the same. So our primary aim was to characterize the utilization of the different approaches. We looked at robotic, laparoscopic, open approaches by race, and then secondly, we wanted to determine whether there was an association between race and important post-operative outcomes, also looking at hernia recurrences and quality of life after ventral hernia surgery. So we performed a retrospective review looking at these three different approaches. Again, using permanent mesh for all of our patients. We only included patients who the wound class was clean, and also only patients who had complete 30-day follow-up. For our data source, we used the Abdominal Core Health Quality Collaborative, which is a collaborative throughout the United States among over 400 surgeons, and we looked over a decade from 2013 to 2023. For our analysis, we did propensity score matching. We were able to match patients 1 to 3, Black patients to white patients, and we did nearest neighbor for our matching. These are the different variables that we used, a mix of demographic, clinical, and hernia characteristics that we felt would be important in affecting hernia outcomes. We then used Wilcoxon rank sum, chi-squared, and Fisher exact testing as appropriate based on the outcomes. So for our short-term outcomes, we looked at 30-day complications, which are all listed here. And for our long-term outcomes, we looked at hernia recurrences at 1, 2, 3, 4, and 5 years, and at quality of life outcomes. We used 2 different metrics. The first was the Hercules summary score looking at abdominal wall health, and so that's normalized to a scale of 0 to 100, with 100 being the best perceived abdominal health by the patients. And for pain scores, we looked at the PROMIS pain score, which is collected in this database, 0 to 100 with the scale being flipped, with 100 being the worst pain score. So this is prior to propensity score matching. In our raw data, you see that the Black patients actually have a higher rate of robotic surgery approaches compared to their white counterparts. And then in our propensity score match cohort, we found that it was a little bit closer, but still Black patients actually had a higher rate of undergoing a robotic approach, which was different from our initial hypothesis. And then looking at 30-day complication rates, these are the 3 complications from our long list of postoperative complications that had a statistically significant difference between the 2 groups. So you can see for reoperations and acute renal failure, our patients who identified as non-Hispanic Black had higher rates of these complications. And interestingly, they had a lower rate of surgical site infections. For our long-term hernia recurrence, this is a combination of both patient-reported and surgeon-reported hernia recurrence. As you can see, the only statistically significant difference is seen at 4 years, but there's not really a dose-dependent response, meaning that at 5 years we don't see that same change. So overall, looking at this data in total, we saw that there was actually no statistically significant difference between all of the years. And then looking at the Hercules score, so again, this is patient-reported abdominal wall health, with 0 being the worst abdominal health and 100 being the best function. We found that there was no statistically significant difference here either. There was something seen at 30 days, but then when you look at 1 year and 2-year outcomes, that difference goes away. And lastly, looking at pain scores, so for our patients who identified as non-Hispanic Black, at all points in time, they reported worse pain and compared to our white patients. I think that this is very interesting, and we had a long discussion, and perhaps some of you will have questions about this, a long discussion about this pain outcome, because even though looking at the changes between baseline and 1 year, 2 year, there was no statistically significant difference, our patients who identify as Black are still reporting higher pain scores, and so this is something that we hope to work on in the future. So in conclusion, we found that our Black patients, in contrast to our initial hypothesis, actually had a higher rate of undergoing robotic surgery. Despite the addition of robotic surgery to our armamentum of tackling ventral hernias, we found that they had higher rates of reoperation at 30 days, also of acute renal failure, and then for our quality of life metrics, we found that they still experience higher rates of pain. So these are two areas that we hope to work on in the future for this patient population, so that not only do we have equitable access for these new technologies to our patients, but also that they experience good outcomes afterwards. So I wanted to thank my mentor, Dr. Zhao, and thank the Yale Department of Surgery at Lawrence Memorial Hospital.
Thank you.